Hello all, we are talking about endocrine problems today. And so let me talk about adrenals. There's going to be a few different chapters about the adrenal glands and about the problems associated with that. Let me share my screen and then we'll start talking about them. So adrenal problems. So adrenal problems or the adrenal hormones are otherwise known as corticosteroids. And a lot of us are more familiar with thinking about corticosteroids than we are about adrenal hormones, but they're the same thing. So there's three different types. There's glucocorticoids. That's easy for me to say. They regulate sugar metabolism and support stress response. Cortisol is the most common glucocorticoid. There are mineral corticoids that do sodium and potassium balance. Aldosterone or aldosterone, depending upon how you want to say it, is that common one there. And then androgens. So if you've ever wondered how a person with an XX genetic chromosome background has testosterone, it's from their adrenals. And if you've ever wondered why a person with XY genetic makeup has luteinizing, FHA, FSH, estrogen, and progesterone, it's also from the adrenals. So people who have their who have surgeries or who are born androgynous without their sex organs are getting those hormones from their adrenals. Let's talk about Cushing syndrome. So Cushing syndrome is chronic exposure to too many corticosteroids. Those adrenals are just in overdrive and they're just doing too good a job. So many autoimmune and chronic inflammation disorders regularly use chronic or corticosteroids in the treatment plan. So if you have like a person who's on COPD or who has asthma and they're on a daily medication regimen, a lot of times those daily medication regimens are corticosteroids. Any sort of people with rheumatoid arthritis or with other autoimmune problems, corticosteroids are part of the treatment plan a lot of the times because they reduce inflammation, great, but they also cause Cushing syndrome if they're at inappropriate levels. So it can be caused, like I said, by too much steroid medication. There can be a tumor on the anterior pituitary gland that releases too much ACTH. ACTH stimulates the adrenals to be able to do their job, including releasing corticosteroids out into the world or into the body. And then sometimes there's a tumor on the adrenal gland or some other tumor in either the lungs or the pancreas, and that tumor is stimulating the adrenals to be able to have that glucocorticoids be released. So manifestations of Cushing syndrome, these are like this is a hallmark diagram. Not everyone will have all of these, but all people will have at least some of these. So there's a variety of thin muscles and muscle atrophy, thin legs, thin arms, this sort of like pendulous abdomen where it's got a really kind of round belly. And then what we call this buffalo hump, and I don't know, there's probably a medical term for it, but if this is what your book's going to use, this is what I'm going to use too. So this kind of clumpy sort of hump that's got going on here, as well as some different pad issues. So care considerations, we can check their cortisol levels in the lab in saliva, in urine, or with a dexamethasone suppression test, where they take dexamethasone and then see what results. Treatment depends upon the cause. So if it's caused by meds, we're going to adjust their meds. We can also remove the causatory tumor, whether they have a pituitary tumor or an adrenal tumor or a lung or pancreas, or we can do cortisol suppression meds, but those are really risky and they're easily toxic. So we don't use them very often unless we just absolutely have to and there's nothing else we can do. Are you done? Okay. All right. So then let's get into the nursing management of people with problems with too much cortisone. So assessment findings will find that they're tired, they have malaise, anxiety, mood changes, emotional lability. They aren't getting good sleep. They have weight gain, but they're not hungry. Anorexia, lack of hunger, weight gain, that's usually not, those usually don't go together. Hypertension. And then in their labs, they'll have low potassium, they'll have bad lipids, they'll have polycythemia, lymphocytopenia, and eosinopenia. So that's a lack of lymphocytes and a lack of eosinophils. And in an X-ray, they'll show osteoporosis. So they won't have enough calcium in their bones and they'll have these weak, brittle bones. Diagnoses, these people are at high risk for infection because their inflammation response is being suppressed by this cortisol. So they have too much cortisol, inflammation response suppressed, increases your risk for infection because inflammation is one of the first things that our body does when it recognizes a foreign invader. They'll have impaired nutritional status, again, because of anorexia, and then they're still gaining weight. Disturbed body image. This is a hard body image to live with, as well as impaired tissue integrity. For planning, we're going to be working with them to relieve their symptoms, avoid serious complications, work with them to try and maintain a positive self-image, and then actively participate in the therapeutic plan. So one of the first things we're going to be doing is health promotion and identifying patients who have an increased risk, either because of their medications or genetics. If we have them in acute care, we'll be doing daily weights, glucose checks, and vital signs. We'll be assessing for infection using the typical signs and symptoms and pain. We'll be looking for loss of function. We'll also be looking for purulent drainage, that foul smelling, weird colored drainage. We'll be looking for emboli as well. So emboli are little blood clots that travel. So like a DVT is a deep vein thrombosis. It's a blood clot that develops down in your lower legs. When it breaks off and starts traveling, it's called an embolus. And those emboli can, one embolus, multiple emboli. Emboli can land in your lungs, they can land in your brain, and they can land in your heart. So if they land in your lungs, you're going to have pulmonary embolism, is what they're called, and you're going to have problems breathing, shortness of breath, because the lung tissue isn't able to participate in oxygenation on the other side of that clot. LOC changes, otherwise known as stroke, and chest pain. An emboli can cause a heart attack. We're going to be giving them emotional support. They may be having surgery on those adrenal glands or on the pituitary gland to be able to have relief of that. So, or any sort of lung or pancreas tumors as well. In ambulatory care, post-operatively, if they've had an adrenalectomy, meaning that their adrenals are gone, they won't have any corticosteroids produced by the body. So we're going to be working with home health. We're going to be looking with medical alert identification. They don't have any stress response anymore. So when it comes to extreme temps or infections or emotional situations, they really have no hormonal compensatory mechanisms. So their fight, flight, or freeze is gone. They may be taught how to titrate their replacement corticosteroids depending upon what's going on, or they may be highly encouraged to have a great, strong working relationship with their treatment team to be able to make any sort of titration for replacement corticosteroids that may be happening. Perhaps they have a lot of, there's a significant other or a significant death in the family, then they're going to need some different help with emotional situations, et cetera, et cetera. If they develop an infection, we're going to need to titrate those corticosteroids appropriately as well. Winter, different steroid levels. Summer, different steroid levels. Spring and fall, different steroid levels. So evaluation, basically, we want them free from infection. We would like them to maintain weight appropriate for height. State acceptance of the appearance. We may not be able to reverse those appearance changes that we saw in the diagram. Skin is healing and maintaining skin integrity. So I'm going to stop here. That was Cushing's syndrome, and I'm going to continue on with Addison's disease in the next recording.